Buddy, welcome back. Um, welcome actually to the beginning of your final undergrad semester in the NAS OT program. It's pretty wild. Honestly, it's pretty amazing. Congratulations for getting this far. And maybe it's a little bit nerve-wracking that this that this is your final undergrad semester. You're graduating at the end of the semester with your bachelor's degree and going on to your level twos. I think it's awesome. So looking forward to being together with you again this semester and teaching and learning together. Welcome to the Cognitive Visual Perceptual course. As I sort of alluded to last semester when we did orthopedics, cognitive perceptual is really way at the other end of the spectrum, where orthopedics is a little bit more, I guess, concrete. Because we're talking about the musculoskeletal system and the neuromusculoskeletal system, the peripheral neuromusculoskeletal system and really directly relates to biomechanics and anatomy. Cognitive perceptual all happens in the brain, right? So this is very much on the other end of the continuum where it is probably one of the least concrete areas of practice for occupational therapists, and you'll learn that all throughout the semester. So some of you will love this course and find it super interesting. I hope you all find it super interesting, but some of you will really enjoy this course because of its complexities, and some of you won't. But we'll get through it together. So. I did want to take this time and number one, sort of go through the syllabus with you and assignments and expectations because we don't have this first class in the first week of classes. So I wanted to do it now so we can sort of hit the ground running when we are all together the first time. This class, let me just share the screen here and tell you just a little bit about this class. Essentially, this class combines vision and visual perceptual and visual motor um, all in one class. And the reason for that is because cognition and vision and obviously perception are all intertwined. So it really just makes sense to put these all in one course. So the way that I like to teach this course is a little bit similar to the way that I taught orthopedics last semester, is to really sort of teach it in the way in a very sort of concrete, clear way of how assessment and really looking at intervention should go. So we're going to talk about the neuroanatomy of, we're going to do vision first. So the first half of this course really is vision and things related to vision, visual, perceptual, visual motor stuff. And then we will move into cognition. And then towards the end of the semester, we will relate everything that you learned to different types of diagnoses, very similar to orthopedics. And when you are working with somebody that has a visual issue or a cognitive issue, and of course, maybe both, you should, and I will say this probably 50 times this semester, you must assess vision and cognition together. So if somebody has a visual issue, you must be assessing cognition at the same time because if somebody does have a visual issue, their cognitive skills will support their ability to function with their visual issue. If somebody has a cognitive issue, visual issues are often masked by cognitive issues and harder to understand how people's vision is impacting their function. So both of these go together. Think of them as partners in life, basically, or partners in your practice, vision and cognition together. So everything, I've opened up all sort of the beginnings assignment things that we'll go over in this video, and we'll take a look at the syllabus and the schedule. So you know the expectations. This course, because it is at the other end of the spectrum, as ortho, it's very complex. There's a lot of layers. It's really like, assessing vision and cognition and understanding how that impacts people's occupational performance is really like peeling away at an onion. It's really more like picking away at an onion, to be honest with you. So this course really lends itself to case-based learning. So you will see that there is a case study assignment, and you will be assigned case studies throughout the semester to do in groups. I'll mix you up into different groups. I mean, there is only 9 of you. I'll mix you up as best as I can in the 4 case studies, and really delving into the complexities that exist in this type of practice. So there is no quizzes. So ortho is very much quiz every week. This this information doesn't really lend itself to very well to multiple choice questions. I mean, I have multiple choice questions obviously in the exams, but the case-based learning is the best way to learn this information. So we have that assignment. We also have the standardized assessment presentation assignment, very similar to what you did last year. However, in the cognitive perceptual course, you will be presenting those standardized assessment presentations during lab in person. And then we will, sort of rotate around the assessments and practice those like we did in lab last year. In ortho, you presented them in a video, in a discussion forum. I'm polling the assessments in person in lab, and I'll talk more about that. You will have another very, very similar. This evidence synthesis assignment is exactly pretty much the same as the one from ortho. The only difference is that you all will be assigned an intervention topic or strategy. So you all will be doing evidence synthesis about the effectiveness of treating different different types of skills, visual or cognitive skills, and not doing an evidence synthesis for standardized assessments this time. And these will be posted in the discussion forums when they are due, and same format as last year, as far as other students, posting Wednesday and then posting again on Sunday to 2 responses. The major difference for the student that is presenting the evidence synthesis is that you will do 6 articles this time versus 4 that you did last time. And again, we'll look at that more specifically. And then the final assignment is this diseases and conditions affecting the eye assignment. I'll get into that. That is the day where you all come in with a presentation and you've been assigned a very specific condition or disease of the actual eye that impacts people's vision, like cataracts, glaucoma, retinopathy, and so forth, so we can all learn about these different types of diseases and conditions. And then besides that, besides these 4 assignments, there are 2 exams this semester, a midterm and a final exam. The final exam is during class time, the final week of classes. So if you remember last semester in ortho, we had the final exam at a separate time because I sort of needed every second of class time almost to fit all the ortho stuff in, because it is such a foundational course. For cognitive perceptual, I can fit in the final exam during class time, so there isn't, we don't have to plan for a separate day and time for the final exam. Okay, so let's just take a quick look at the syllabus. All of the things are on here, everything that you're used to, your learning outcomes, and so on, the textbooks, all of these things here. This is the list here of pretty much the things that I just talked about. There is also a participation grade for this course, just like there was for ortho last semester, because participation is crucial in class, in lab, and obviously in clinic for you to learn as much as you can and to get out of this course as much as you can. Um, Please, as I said last semester, try to do the readings ahead of time. Come to class prepared. You are graduating at the end of this semester. You're moving on to your level two, so we really should be continuing to shift classroom into discussions. And again, this type of topic, cognition and vision, lends itself to discussions versus me just talking at you all the time. And I'm not really a fan of that anyway in classrooms, as you know. So just be prepared for different, discussions, questions, activities, and things in class. So in order to do that, try to do some of the reading. I try to minimize the reading as much as I can. I don't, you know, assign 5 chapters before class. Nobody's doing that. So at the very least, at least take a look at it, skim it, look at the PowerPoint ahead of time. Just know what we're going to be talking about and be prepared ahead. Um, and yeah, so here's sort of the percentages, a little bit more description for each assignment that we just talked about. Um, the percentages are all set in Moodle as well. Each exam is 20%. Um, the discussion forum posts that you are posting on, not as a presenter, is worth 10%. Diseases and conditions of the eye is 5. The case studies are a total, they're worth 15% altogether. You'll be doing 4. Um, the standardized assessment presentation, 10%, everybody's doing one of those. Evidence synthesis, 10%, everybody's doing one of those. And then class and lab participation, 10%. Okay. I did want to take a minute here and talk about the class schedule. It's a much different design that I used, last semester. So I just want to orient everybody to this because I don't know, it helps me kind of know what's happening. Hopefully it helps you kind of know what's happening in this class. So it's set out sort of horizontally for each week. And like, here's week 1. This is what we're doing. We're all celebrating Martin Luther King, and I'm going to provide you this recording, right, for the topic for you to watch. Here's the reading assignments. These are posted on Moodle. If there is something going on for the case study, whether I'm assigning you the case study that week or the case study is due that week, that will be listed in this column here. If there is an evidence-based presentation or discussion forum, that will be listed here. And then if there is going to be assessment presentations, that'll be listed here. Obviously, there isn't any for next week because we're not going to be together. But as you can see, the evidence-based presentations and the assessments are already assigned for everybody. So if you haven't, please go on to those links on Moodle and see what you're assigned for and make sure you get it in your calendar for when you are presenting those for the week. These are things that you can start working on ahead of time. By the way, if anybody is like really working way ahead of time on their evidence synthesis, I'm happy to open the week and the PowerPoint and the readings ahead of time for you to work on that. So let's just go forward a little bit more. Again, this is like the first week we're together, week 2. This is what we're going to be talking about. Here's the reading. There's no case study. There's no evidence synthesis. And then me and Johanna will be doing and showing you and practicing vision assessments during lab. So those are sort of the assessments for the week or what's going on. I did want to alert you to this mauve pink sort of color here when that is the pink color on the schedule indicates when clinic stuff starts. So if you remember, if I sent you that email, was it yesterday? I think it was yesterday. I sent it to you. I'm not going to be using clinic time, obviously not the first week and not the second week, but we will start using clinic time February 3rd, which is week 3, which is your very first virtual client. We do have 2 virtual clients for clinic, like we did last year. For this course, because we do vision first and then we do cognition, you have 1 virtual client for vision initially. And then when we get down into the information about cognition, then we will have a second virtual client. So that's not going to be until April. So you just have one virtual client this for this course before clinic starts. Excuse me. So in your calendars, be prepared to use your clinic time starting February 3rd. And then clinic starts February 10th. So clinic does start earlier this semester than it did last semester because you are more prepared for clinic than you were last semester. So we can start earlier. But the nice thing about that is clinic ends earlier. And clinic this semester is only 7 weeks. um, for a lot of different reasons, because there's a lot of uh, things going on in this semester, a lot of ceremonies, a lot of things happening at the end of the semester. There's the spring break in the middle of the semester. The kids have February break and April break. So it just works out best for clinic to run 7 weeks. So clinic will end, you know, unless you have makeups. For on-campus clinic will be March 31st that week. And then RCN people, your clinic will end April 7th. And the reason your clinic will end April 7th, RCN people, is because you cannot go to RCN over February break because they go by the school schedule. So you're going to miss sort of RCN that first week. So you'll be a week off from the on-campus people. And then just like last semester, we have time scheduled at the end of the semester for makeup sessions. So this clinic will end even sooner than clinic did last semester, and so on. So that is just kind of the information on the schedule. If you have any questions, um, you know, let me know. And just wanted to show you. So this is what it looks like for like the case study or the evidence synthesis. So the very first evidence synthesis is due the week 3. So you can look on here whether you're the one presenting, or if you can look at if you're other students that are not presenting and be like, oh yes, I need to do a forum, do a post in the 2 replies. Right? And then you can find that here. And then the first case study is assigned will be week 5. So I will have it on this schedule when it's going to be assigned. And then with the case study, the case studies are due the following week. And during lab, we will meet and you will have like small group discussions about the different case studies that you are working on, which again, because this information is so complex, it really helps best to talk about cases, talk about all the different details and different ways that you are thinking about assessing and you're thinking about from an intervention perspective. Okay, so I will go through sort of these assignments really quickly. As I said, this presentation of standardized assessments, here is the grading rubric. It's very, very similar to, it's pretty much the same thing. Same rubric as last year. You're assigned a standardized assessment, right? Here's all the things that I want you to present about the standardized assessment. The difference this semester is you all are assigned a standardized assessment and you all will be presenting the assessment during lab in person. I still would like a video recording of either a full administration of the assessment if it's a short assessment, or at least pieces of the assessment if it's a long assessment. So other students can take a look at that video and see what that assessment really looks like. And then we will go around and I'll pull the assessments out and everybody can go around and sort of rotate around the assessments and have some practice with the assessments. Okay, so that's all here. That seems pretty straightforward to me. But of course, if you have questions, let me know. I am going to pop down to the evidence synthesis because this is probably also the other easy one to tell you about. This is exactly the same as last semester, except you all are assigned an evidence synthesis project to do throughout the semester, so take a look at that. But this will be posted in a form for the week. And other students in the class will be posting about it and responding about your presentation. Very, very, very similar rubric. This time, though, you will be taking a look at 6 articles when last year it was 4 articles. Okay. Let me know if you have questions about that. The two different assignments here, let's talk about the um, conditions and diseases of the eye. This is not like a huge lift, I don't think. But there is one day on, get off of there, the schedule where you will all be presenting about diseases and conditions of the eye, which is week 3, February 3rd. There will be 9 presentations. Your presentation should not be any longer than 10 minutes. It's a very quick overview about the condition or disease that you have been assigned to. And here's all of the things that you should talk about. What is the condition? What's the technical name or layman's term name if there is one? How does it happen? How does it progress? Who's at most risk for it? Is there a typical age range? What part of the eye? What is their medical treatment for? And how does it impact vision and occupational performance specifically? So 10-minute presentations on those, and everybody is assigned. And those will be in-person, in-class presentations. And then finally, probably the most complicated or the newest assignment is the case-based learning. So there are going to be 4 cases that you are going, case-based assignments that you're going to be assigned throughout the semester. Um, the first one is that week 5, you'll be assigned a case study on, visual motor, visual perceptual issues or challenges. And you will be assigned in groups. There'll be groups of 3, and you'll work on the case together. Here's what I want you to, what is expected in your assignment is, what is the impact on occupational performance that's going on with this person? What's your evaluation plan, your goals, models of practice, right? And what is your intervention going to look like, accommodations and compensations. And we can talk more specific about these once we are in person. You are going to find 2 evidence-based articles. You're going to relate the articles to how you're going to use them in your intervention plan. And then, as I said, you'll have 1 week in that group to finish this case. And the following week in lab, you will get together with the other groups and talk about your case. You'll present your case basically to the other people that were not in your group. And then you'll talk about your cases together. And so that's what this 5 points is at the end. And I have a whole facilitated case study presentation thing to follow. And we'll talk about that more specifically when we get together. I do have, since this is sort of like a newer, a little bit more complicated assignment for you all to do, I have a case study example that was done a couple of years ago as a guide for you. Okay, so that's just a sort of quick overview of the course and the assignments. And again, we'll go into more detail when we're together, answer questions, and so on. But just to give you an overview of expectations going forward. Okay, so let me get into the neuroanatomy of review of vision. This is crucial. I totally understand that you've had neuro and you've had anatomy in the past and you've had A&P and all that kind of stuff. Those were a long time ago. So this is really important for us to move forward when we're talking about assessment and intervention. I'm going to highlight the key things that you need to pull back into the forefront of your mind about neuroanatomy and as it relates to vision. Okay, so here's our objectives. Quick review on the anatomical and neurological structures of the eye is what I'm going to do during this video. And then when we get together on our first time together, we're going to be talking about visual assessments and practicing administering those in lab, and then also obviously discussing intervention strategies. So I want you to really think about why vision is a critical area for OTs to assess and treat from an adult perspective and a pediatric perspective across the lifespan. Um, Sometimes if you're sort of a pediatric focused person, you're thinking about developing visual perceptual skills, developing vision skills, developing visual motor skills and handwriting and eye-hand coordination and so on. But vision impacts, and I'll just put it out there and say vision impacts everything that everybody does every day. Boom, right? So it is crucial as an occupational therapist, no matter what setting or who you're working with, that you understand how to assess and at an entry level, how to intervene when people are experiencing visual challenges. You might not be working in a setting where vision is a key area or a specialized area, but every client that you work with, their vision will obviously impact their occupational performance. Or you may be an OT that moves on to specialize in visual issues. So, quick overview about who treats vision problems. Lots of different people are involved. Vision is very complex. So there's a lot of different providers that are involved when problems arise with vision. So at the top is an ophthalmologist. So an ophthalmologist, if you have never seen an ophthalmologist or don't know, an ophthalmologist is a medical doctor. So an ophthalmologist has gone through medical school. They have their MD or their DO or whatever type of medical school that they went through, and then they specialized in ophthalmology. Um, so ophthalmologists are, people that see ophthalmologists see them for when there are specific medical things that people need, like if they need prescriptions, if they need surgery, right? And so on. Medical emergencies like retinal tears and ruptures and so on. Those are ophthalmologists because an ophthalmologist has a medical degree. They can write prescriptions, they can perform surgeries and all those fancy things. There is also an even more super specialized neuro-ophthalmologist who becomes an ophthalmologist and then specializes in neuro-ophthalmology, and they see people that have visual issues that are related to a neuro issue. So if that's a central nervous system issue, right? Cranial nerve issue or stroke or traumatic brain injury, cerebral palsy, something like that, that has impacted the person's ability to see versus an eye issue, where a regular ophthalmologist might see a person with just eye issues. An optometrist is a doctor of optometry. That's what that OD means. So they're the ones, they are not a medical doctor, so they cannot prescribe medications or do surgery and so on, but they can prescribe glasses. So they are typically the first people that somebody will go to, right, to have an eye exam, get, glasses prescribed, and so on, prism glasses, things like that as well. Some optometrists do specialize in developmental vision, so they very much specialize in, kids and that have issues with their vision. An optician is the person that makes the glasses and contacts. So the optometrist does the eye exam, prescribes the glasses, the contacts or whatever. That goes to the optician, and the optician is the one that makes the glasses. Then there's the teacher of visually impaired. So if you work in early intervention or in school age, you will probably work with a teacher of visually impaired on your interprofessional team. That is a teacher who has specialized in working with kids that have visual impairments, and their goal is helping them in their academic success. In the school system with accommodations and compensations around school. And then there's the orientation and mobility specialist, which is different than the teacher of visually impaired. The orientation and mobility specialist is a person that helps somebody who is visually impaired learn how to navigate their environment and, ambulate or mobilize if they're using a wheelchair through their environment. So they're the ones that teach people how to use a white cane. They're the ones that teach people how to use their other senses and figure out where they are, where they're going, and so on. So those are just a quick list of different people. There's even more that we'll talk about as we go forward in this semester, but just to frame those people for you. Okay, so this here is for you to take a minute and take a look at the different labels here on this picture of the eyeball and the anatomy of the human eye. And can you pull from your brain some of these labels? That's why they're all covered. Can you remember what some of them are? I would like you to just take, 5 minutes and see if you could name these. Um, just by, taking a look. Can you remember what these are? These are not all of the anatomy of the eye. The eye is incredibly complex, but these are key things to remember and that we need to know as occupational therapists about the anatomy of the eye. Okay, so pause here because I am going to move into the next slide that has the answer. So pause here and see what you can name. And then here is your answers, right? So hopefully you knew where the pupil was and the lens and the cornea and the iris. These are the ciliary bodies, the suspensory ligaments. This is important when we talk about the fluid of the eye and also how the lens changes, right? The sclera, the choroid, and the retina, the fovea, the optic disc, which is the blind spot. These are all important in understanding as we move forward different diseases and conditions of the eye. And then, of course, the optic nerve here. Okay. So, fluid chambers. So, fluid in the eye is extraordinarily important for the function of the eye. Remember, there are three chambers, the anterior, posterior, and the vitreous chamber. I want you to spend a little bit of time and just think about the different fluids of the eye. This vitreous chamber, remember, is just a huge open chamber. There's really not much in there. All of this stuff in the back, right? The retina and the optic nerve and the sclera and the choroid are all back here. The posterior chamber is where the humorous fluid is created, and then it flows through to the anterior chamber, right? To keep those parts of the anterior chamber hydrated. This is another way to look at the anatomy of the eye. It's a side sectional part of the eye. So back here is sort of this posterior cavity, which is the vitreous chamber. Um, and here's the suspensory ligaments, right, that are attached to the lens. Remember, those are the ones that kind of change. The ciliary body is the one that moves the fluid from the posterior chamber, which is here, posterior chamber into the anterior chamber here. And again, this is just sort of a side view. There is the lens itself, the iris, and the cornea, and so on. I just really like this view because we spend so much time just looking at sort of this frontal view, and so sort of reminding ourselves and how this all relates together, looking at it from a different way, sort of back to front. So remember in the retina, we have the photoreceptors, which is the rods and the cones. Can you remember how the rods and the cones are distributed in the retina? If not, I want you to look it up, find out, remember what do the rods do, what do the cones do? That's really important to know. And we are going to talk about cranial nerves. So cranial nerves, there are three important cranial nerves in the control of our eyes that control the muscles of our eyes. Here's another question for you before you change the slide. Can you pull from your brain the cranial nerves that control eye movements? Because oftentimes when people, especially from a neuro perspective, have issues with eye movements, it's because of a cranial nerve issue. Here's the three: cranial nerve 3, 4, and 6, cranial nerve oculomotor, cranial nerve trochlear, and cranial nerve abducens. Again, these control the muscles of the eyes. I'm not going to go over these specifically, but you should know what these three cranial nerves do and how they move the eyes. Okay. I am not going to question you or test you on the specific muscles of the eye, but I do want you to know, I mean, it's super interesting and it should make sense, the muscles, but that's anatomy. But you do need to know the movements that these cranial nerves do. Because in assessment, if you notice that the person is having a really hard time moving the eye up, down, and medially, you would immediately think cranial nerve 3. There's something, possibly really something going on with cranial nerve 3, and they can't lift their eyelid. Or if they're having trouble depressing the eye when the eye is adducted, could this be the trochlear? Or moving the eyes laterally, or the eye, one eye or two eyes. And we'll talk about that in assessment, whether you're assessing one or two. Okay, so this is really important to know these three cranial nerves and what they do. This is another chart, if you are a chart person, um, that shows you here's cranial nerve 3, here, here, and here. Ocular motor nerve does most of the things. There's 6 and there's 4. Here's another visual for you that has the muscles. Again, I'm not gonna test you on the muscles, but it has the nerves in here. Here's 3, here's 6. Um, Here's 4. But if you need to see a visual of, the eye movements itself, what they're talking about, right? Lateral movements here, um, versus gaze downward and right, like what, there's just a visual for you of what that looks like, what those movements look like. Okay, so in adults, oftentimes ocular motor impairments happen after an ocular motor means the muscles. I want to make sure that you are clear on what we're talking about right now. We're talking about the integrity of the eye muscles and what the eye muscles are doing. That's what ocular motor means, the ability of the eye muscles to move the eyes. So after traumatic brain injury, often people have issues with vergence, that's convergence, where the eyes go together, or divergence, where they come apart. And accommodation, can you remember what accommodation is? Give you a second to think about it, right? When something comes closer or farther away, the lens changes to focus. After a stroke, strabismus is more common than vergence or accommodation, and strabismus means that one eye is not lining up with the other, or also cranial nerve palsies of sixth and fourth cranial nerve are common. Oftentimes, ocular motor impairments in children happen also with acquired brain injuries, such as cerebral palsy, anoxia, different genetic syndromes, and so on. Another very important thing for you to pull from your memory is the route of visual stimuli from the retina to the cortex. So if you're feeling crafty, this slide here is for you, and I know you did this at least in neuroscience. I'm pretty sure Connie does this in neuroscience, but I would like you to again to take out a piece of paper and draw a diagram just for yourself, starting with the eye. Draw the eyeball, both eyeballs, and then the root of the optic nerve. Make sure you have the optic chiasm, right? And which which ones cross and which ones don't cross. And then along the way, can you identify 5 anatomical structures? So pause here and take a minute to do that. And then, of course, in the next slide, here is the answer for you. Okay. So what doesn't cross? The lateral portion of the optic nerve. What does cross is the nasal portion. Okay, and that happens in the optic chiasm. That is extraordinarily important to understand when there is a lesion and where the lesion is and why the vision is affected the way that it is. Here are some things that you could have um, uh, put on your diagram, right? The 5 things to put on your diagram could be the optic nerve, the optic chiasm, the lateral geniculate nucleus. Remember, this is where um, the uh, the optic nerve sort of spreads out even more. You can certainly have the retina, the lens, things like that could also be in your diagram here. But these are the most important things for you to know and for you to understand um, from a neuroanatomy perspective and to understand um, how vision is perceived in the brain, how it comes through the eyes and how it goes into the cortex. So another thing to remember and to point out, here's a temporal or lateral optic nerve. Remember, our eyeballs are spheres. So the visual field from the temporal retina, the information that's coming in is from the central visual field or the nasal visual field. I see that on both sides here. Okay, can be confusing. And then the visual information coming from the peripheral field is getting picked up by the nasal retinas, the nasal side of the retinas or the nasal side of the eyeballs. Okay. And then the temporal side doesn't cross and the nasal side does. So right, it gets very complicated, but the more you draw it and the more you think about it and the more you look at it, um, the better you'll understand it. Because this is, and we'll look at this again, but I just want to introduce this to you from a optic nerve perspective and a cortex perspective, like from a stroke or traumatic brain injury or some other acquired brain injury and so on. It really matters where along the optic nerve and where in the cortex a lesion occurs, um, and then what the result of that lesion is on vision. So just to orient you, this is the same picture that we just saw in the previous slide. These yellow lines here represent where a lesion occurs along the optic nerve. It is all along the right eye, but you could flip it over onto the left eye. Down the side here, these numbers correlate to the lesion, right? So number one, if there was a lesion on the right eye, right in the beginning of the optic nerve into the cortex, would lead to right eye blindness. So the blue over here is where vision loss is, okay? And the reason you can see here, if a lesion happens here, it's only going to impact the right eye, but it's going to impact the whole thing, right? Because the optic nerve, the nasal, and the temporal visual information is all bundled up together into that optic nerve. Okay, and then we can look at number 2. Here's the chiasm. Here is where which ones cross? Can you remember? Is it the temporal optic nerve or the nasal optic nerve that crosses? It's the nasal. Okay, so number 2, if there is a lesion that happens right at the optic chiasm, would it impact all of the optic nerve on both sides? No, because the temporal optic nerves don't cross. Okay. So you would have vision loss in the peripheral visual field because remember, we have a sphere for the eye. So the nasal retina takes in the peripheral visual field. Okay. This is called a heteronomous, lovely word, anopia. Okay. This number three, now we're still on the optic nerve at the right side. If this lesion happened right here, now this is a much smaller lesion. It's at the optic chiasm, right? But it's really only impacting because this is where the optic nerve after the chiasm starts to spread out a little bit. Just this temporal retina or temporal optic nerve that didn't cross. So here we have nasal loss of vision just on the right eye. Okay, because remember the temporal retina takes in the nasal or central visual field, and so on. Okay, this is called just an anopia because it's one eye. If you hear heteronomous or homonymous, that means it's two eyes. Heteronomous or homonymous anopia, it's two eyes. If you just hear anopia or hemianopia, it's just one eye. Now, the most common are these 4, 5, 6, and 7. This is where the middle cerebral artery mostly brings, oxygen to the optic nerve past the chiasm here. And the middle cerebral artery is the most common artery where people experience a stroke. Okay, so these are the most common things that we'll see 4, 5, and 6. So here's 3 different areas where 4 can happen. Okay. This is where the after 4 is where the radiations start to open up. Okay. All the way to the cortex. Now, if 4 happens, this is where now we have the nasal optic nerve that has crossed over on the left side and the temporal optic nerve from the right side. Okay. So now we're back to 2 eyes. Okay. But because we have the nasal optic nerve on the right and the temporal optic nerve on the left, we have loss of the peripheral vision on the left eye and loss of nasal vision on the right eye. This is called homonymous hemianopia. Now, the reason this is heteronomous and this is homonymous is because these are different sides and this is the same side, right? Hetero means different. Homonyma means the same. Okay. This is one of the most debilitating visual issues that people can have after a stroke when they have lost nasal vision on one side and peripheral vision on the other side. Their vision is very chopped up. Okay. 5 and 6 is where those optic radiations open up. And so now the optic nerve is sort of opened up into quadrants instead of a whole side. Okay. So 5 and 6 can happen where people lose a quadrant. Okay. So here we have a lower, or we call it an inferior homonymous hemianopia. So it's the same as this, but the radiations have split out. So we just have a quadrant here. Or 6 is a superior homonymous quadrantopia. I know these words are so fun to try to say. So these are quadrantopias instead of hemianopia. They are homonymous. This is inferior. Number 5 is inferior. Number 6 is superior. Okay. And then number 7 is just showing you if the optic nerve gets hit and gets hit by a big lesion back by the visual cortex, we can also, people can also experience the same as number 4, homonymous hemianopia. Okay, because it's still nasal from one side and peripheral from the other side. Okay. So hopefully this has made sense. We will bring it up again. We're going to talk about it again. Please, have questions. If you don't understand this, please come and come with your questions and we'll talk about it more. This is really, really important for you to understand where there are optic nerve issues, and why people have the vision and type of vision loss that they have. This will lead you to understanding how to assess for these vision losses and also intervention. Okay, two streams of information from visual cortex. Can you remember what they're called? Streams, dorsal and ventral. And what type of information do they relay? Take a minute and see if you can remember what type of information they can relay. I'm going to give you the answer on the next slide. So if you want to pause it, go ahead. I really like this picture here. Hopefully, if you're a visual person, this helps. Here's the eyeballs down here in the roots. Here's the visual fields, right? Right eye, left eye. Here's the optic nerve. There's a little brain, and that's the midbrain. There's the lateral geniculate bodies. Here comes the optic radiations and the optic lobes. Here goes the dorsal stream and then the ventral stream. The dorsal stream is fast. So this visual information goes really fast to the dorsal stream. It's not really interested in details. It's interested in finding out, in searching to find something, or a quick visual look when your attention is alerted, and also to guide your movement. So this vision happens really fast, but there's not a lot of detail. Not a lot of detail, okay? When you are doing eye-hand coordination stuff, especially like throwing a ball and especially along the gross motor perspective, you're not really paying attention to the detail of the ball and, the little bumps on it, or, whatever, or you're not paying too much attention to the detail of the target. You just want to quickly see the target, quickly see the ball, and get the ball to the target. The ventral stream is all about detail. This is really, I call the ventral stream for vision the nosy one. Okay, the ventral stream is really nosy, and it's also slow, right? You cannot determine all the details visually unless the information is happening slowly. Okay, the dorsal stream goes to the parietal lobes really quickly just to get a general sense of the visual information. What is it? Right? Finding a person in a group. Where is that person? Oh, there they are. You're not paying attention that much to what they're wearing, or, so on. You're just really general information. Ventral stream, nosy, needs all the details. What is the color? What do the letters look like? Very specific thing about recognizing people. That's where facial expressions are recognized and so on. So it's really looking at the details. Ventral is slow, dorsal is fast. Ventral goes to the temporal lobes. Okay. All right, and this is the final slide, just to sort of frame our conversations when we are together on the 27th. This is the model of visual perception that was created by Mary Warren, who's an occupational therapist. We affectionately call her the mother of visual perception in occupational therapy. This is her model. And I should say, most of assessment and intervention uh, things that happen centered around vision in occupational therapy, at least in some level, are grounded in Mary Warren's model of visual perception. And we will revisit this multiple times as we're talking about vision. But this is sort of the hierarchy of vision and visual perception, which goes all the way up to the top in how people use their vision to interact with their environment and to interact with their occupations. At the bottom here, we have the very foundational efficiency of your eyeballs. That's the oculomotor stuff. The integrity of the eyeballs. That's the anatomy, right? And how well that is working. And then your visual fields, which we just looked at, right, with your optic nerve. How is the person perceiving the visual information that's coming in from their different visual fields? The next step is visually fixating and visually attending to the whatever it is in their environment that they need to attend to, recognizing patterns, putting things in categories from a visual perspective, then visually remembering things, then using your vision with your cognition. This is why we teach vision and cognition together. In order to use your vision to do cognitive things, to do social things, to do motor things, and so on. Okay, so I will leave you with that, and I will see you on the 27th, or please come by my office and stop by and say hello. I would love to see you before then, and come to the class on the 27th with questions from this video. All right. Have a good one, guys. Take care.